Well, good morning, everyone. My name is Dr. Stephen Hancock, and I have the pleasure of presenting is data driving value-based behavioral healthcare being used to get results? Kind of a mouthful for a title, right? Uh, Today, what I want to accomplish is I'm going to define the 8 features of value-based behavioral healthcare. I'm going to offer you 9 methods of evaluation through research. There are 3 primary areas of impact, problems and concerns that we have, as well as open up hopefully about 20 minutes for questions and answers. This is a little bit atypical of how I present. I'm used to being in a room where I can get more involvement. But what I am going to do is go through the presentation because there's quite a bit of information. And then once we're finished, I'll look through the questions and see if we can't nail down some of the things that you guys are thinking about. So when people look at defining value-based healthcare, behavioral healthcare, it's basically an approach to mental health and addiction treatment that focuses on high quality delivery as well as controlling cost. Its response is the rise in healthcare expenditures and to improve our quality of care. You know, for instance, I'm sure everyone here is well aware that after the pandemic, we're obviously seeing a huge amount of access to mental health care. There's rising costs. There's a global shortage of counselors and psychologists and psychiatrists and social workers. I'm sure you're seeing in your practices increases in sensitivity and reactivity, relationship difficulties, increases in domestic violence, and social and educational delays. What we're also, so in defining it, we're looking at other things like the increase of cost of living, professional obligations. Drawbacks are psychology, social work are often considered soft science, and the science tries to produce hard evidence, but it often relies on subjective interpretation, correlation results, and less predictability. And it also forces us to kind of have the conversation in mental health in general. What do you actually consider change, right? Key features when you use data-driven behavioral healthcare is it's a focus on outcome measurement. So this is one of the 8 features of defining value-based healthcare. In that, you want to improve patient outcomes, track progress, and use data to inform decisions about treatment. You have conversations about payment models where it's value-based as opposed to the pay per service usage. So instead of being paid solely for providing the services, providers may be compensated based on the quality and effectiveness of their care. And this can be included in payments or bundled payments, pay for performance, or shared saving models. And it attempts to put an emphasis on the population health management, addressing behavioral needs of the entire community as well as the patient population. Preventative strategies, early intervention are all an attempt to reduce the overall burden of behavioral health issues. There's also an emphasis on the integration of care. So getting GPs, psychologists, social workers, counselors, holistic providers, physical therapy, speech therapy, the long list of things that people could use to improve their situation and get them on the same page so it becomes more patient-centered, as well as something that addresses multiple needs, not just one here or there. It also focuses on data and technology. They want to utilize AI, electronic health records, health information, and again, the outcome management that we discussed earlier. And when we get into the conversation a little bit later, we'll talk about some of the concerns that people have. There's many conversations about a nationalized healthcare system. What would that mean for patient records? What kind of information is included in those records? Especially when you talk about mental health and we talk about intimate aspects of people's lives, should that be included then in those kinds of records? So it definitely creates a lot of concerns, but also we can utilize that information to improve patient care as well as the impact on the community. So we'll get into that a little bit later in the presentation. It also is patient-centered. So the focus is on delivering a tailored experience for the individual and ensuring their participation in that experience. Again, as I mentioned earlier, prevention and early intervention, especially with the youth. Obviously, like with psychoed testing for school systems, getting ahead of difficulties, whether they're behavioral or psychoeducational. This also then helps us reduce the stigma and increase the awareness of mental health issues. So, for instance, one of the programs that Dr. Ray and I have been working on with the island for psychoed testing, the goal is to not only provide testing, but to give a wide range of where the gaps are so that the educational system can close those gaps. So by using psychoeducational testing, as well as some statistics, we can give them a much better picture of what kind of programs would be an asset to the students. And then there's always the quality improvement conversation, which is the kind of the core principle, which is the ongoing assessment and adjustment care processes to achieve better outcomes and higher value. So basically, value-based behavioral healthcare seeks to address the shortcomings in the traditional fee-for-service model, where providers are incentivized to deliver more services without necessarily ensuring the quality of care. I think where you hear that kind of conversation is when you hear people discuss, oh, I got referred for this test. Do I really need it? But then the argument is, well, if I don't test for it and it's there, then I'm negligent. So you see the back and forth. And by shifting the focus to outcomes, cost effectiveness, and prevention, it aims to provide better healthcare to individuals with mental health and substance abuse disorders while also managing the cost. You've seen this approach has gained a lot of traction in recent years in the healthcare systems, as insurance companies as well as the healthcare systems are looking for ways to improve the delivery of behavioral health services. So that's kind of the basic outline and kind of general description of what value-based behavioral healthcare is. Now, it focuses its research on assessing outcomes, quality, and cost effectiveness of mental health and addiction treatment services. There are common research methods and measures that we use for that. So, for instance, patient outcomes. At the end of when someone terminates, they might use a survey, a questionnaire, talks about their mental health status, well-being, satisfaction, things like that. There are more standardized measures, like you got the Beck Depression Inventory, the General Anxiety Disorder 7, or even the Patient Health Questionnaire. And again, by giving those at the beginning of the treatment as well at the end, you can see and track some kind of progress. And historically, those are on a rating scale. Also, relapse rates. The interesting thing about relapse rates, I've been practicing in Bermuda for roughly 17 years now. And I have people that I saw 15 years ago will come back, and sometimes it's the same thing and sometimes it's not. And so, although they're back in my office, the problems are different. So, relapse, I can see that if it's like something for addictions where it's very specific. But when we start talking about the wide range of mental health care, it can get a little bit tricky. Some of the other things we measure with research, treatment adherence and engagement. If you look at serious mental illness, let's say schizophrenia, for instance, it has a very poor treatment compliance is terrible with severe mental illness, and getting sometimes follow through without medication is going to, again, kind of misalign the relapse rates. People who are bipolar, many of them often like that high they get, that energy, that even though it may not be based in reality, it feels good. And when you sedate through medication, that feeling they get is uncomfortable. And then also having people use evidence-based practices. So, for instance, there are a lot of research suggests that most treatment modalities are effective. However, things like like a paranoia, a phobia, something along, not paranoia, a phobia, some type of anxiety seems to do well with cognitive behavioral therapy. So it's using evidence-based practices. And also same thing, knowing when to give a medication or referral, when not to. Cost effectiveness, again, part of the research and the cost benefit analysis, where are the costs of what is being provided uh, produce enough an outcome to justify them. Um, those are going to be particularly interesting for societal costs like hospitalizations or criminal justice involvement. Also, resource utilization, measuring the utilization of healthcare resources, like the frequency of emergency room visits or hospitalizations before and after treatment. I think in mental health care, a lot of times when I get a referral from the hospital, someone's had a panic attack and they've not recognized it as such. And so they'll go to the ER believing they're having a heart attack, but they'll go in, their heart rate's actually fine. Their blood pressure may be slightly elevated, but there's no physical indication of a heart attack. So then I often would get a referral from the ER for mental health care. Also, speaking of the healthcare utilization, what are the readmission rates, whether that's inpatient or again the ER, and again, how many times and how often are people using in the emergency room for behavioral healthcare issues? Another thing we measure and research is the population health. I mentioned that earlier. Preventative measures, monitoring efforts to prevent mental health and substance use disorders through education, stigma reduction, and early intervention. Things like sometimes, like on National Depression Day in the States or National Anxiety Day, they'll have providers go out and just do general surveys. Maybe the Beck Depression Inventory, maybe the Beck Anxiety Inventory, just to give people information to let them know where they stand. A lot of times when you've had a lifelong experience with anxiety, you've grown accustomed to it, and you may not even know that you're actually going through it. Sometimes even depression. Depression isn't always sadness. It's not always someone curled up in a ball crying in their bedroom. Sometimes it's expressed as anger, memory deficits, sleep disturbances. There's lots of things that sometimes people have learned to endure and not necessarily are able to put a label on it that they can actually recognize as mental health. Patient satisfaction surveys are another way to measure outcome. I think partly where some of these things struggle for the most, and I imagine many clinicians in the room have this, especially in Bermuda. I've tried to do patient experience and satisfaction mail-ins, surveys, basic demographics, and people are very hesitant to fill that out, even if it's a patient survey. We virtually got maybe, I think in the 4 or 5 years we actually did it, we maybe got 1 or 2 a year back, and we're talking roughly the practice would see on average 300 to 400 people a year. So the response rates were terrible. So again, it would give us good information, but it's about actually obtaining that information. Other ways research, value-based payment methods. People have pushed around ideas of bundled packages, pay for performance. If people aren't feeling like they're getting good treatment, insurance companies may reduce the amount of reimbursement, or conversely, if it's high, they might increase it. And that gets a little bit sticky, especially given sometimes therapy is not always fun. Sometimes it's painful. And sometimes people will hit marks and need a break before they come back. So again, it gives us ideas on how to kind of incentivize good treatment, but there's a lot of, like I said earlier, soft science variables that we would have to account for. There's also an emphasis on data analytics. And that's, again, another sticking point. I remember it would have been roughly, I want to say 10 years ago, there was a conversation in Bermuda about standardizing health records. And, it is really good at identifying trends, gaps in care, and opportunities for improvement. When we start talking about mental health care, again, it throws in a wrench. So for instance, I worked in a domestic violence sexual assault shelter. There were, obviously I had conversations about rape, molestation, things of that nature. And sometimes those are explicit. And I'm not always certain that that kind of information is necessary in a file that would be access to a physical therapist or to a dentist or to someone else. Again, if we're trying to build out this database of information so that we can get predictive and we can try to identify problems, psychology, social work, social social issues, it throws a wrench into the conversation. And both for providers as well as for the individuals who are, talking to us. Long-term follow-up, again, having opportunities to talk with people to measure sustainability are the things that were worked on in the setting where are they sustainable. You know, when you look at value-based healthcare, the research involves large data sets, statistical analysis, and longitudinal studies to assess the effectiveness in the interventions and the payment models. And ultimately the goal is to provide a comprehensive understanding of how these services impact the well-being of the individual, as well as the overall healthcare system. Researchers, healthcare organizations, and policymakers use these measures to make evidence-based decisions about the delivery and the reimbursement of behavioral healthcare. So when we look at the impact, I mean, there's tons of impact, but I kind of am going to just focus on three specific. And again, I'm sure that if you go and do some research, you'll find a lot more. And I'm going to try and throw some statistics in it. And I'm going to give you, it's going to be US statistics, and I'm going to try and normalize it against Bermuda numbers. So let's see here. So, if we look at the National Institute of Health in the States, recently, it suggests that 1 in 5 adults is struggling with mental illness. And probably what is the more devastating aspect of that is only half of the people receive treatment. So in practicing in Bermuda for the last 17 years, I just went back, briefly ran the numbers. And so again, over 17 years, I've seen roughly 2% of the population in Bermuda for therapy. And that's just for the therapy side of it. I've done a lot of testing for government organizations. So if you threw on all the testing that I've done, that might push it up to maybe I've had contact with 4% of the population. And so when you look at just me, and I've seen 2%, and you throw in just the people in my office, we're pushing maybe 5 to 6% of the total population of Bermuda has been through my office. And there's many healthcare facilities on the island, so you can kind of extrapolate the numbers. So there's a high need, and there's always been that need. Lots of conversations recently have talked about the pandemic and the outcome of the pandemic. And what I've often said to them was, it's always been there. So when I opened my doors in Bermuda, it took me less than 2 months to fill my caseload. And just to give you a reference point, the average psychologist in the States sees 18.6 people per week. And on average, I average 35 billable hours per week. So that just gives you an idea of the level of need. And so when we look at mental health care, if we're seeing this and we still know there's stigmas and we still know there's a lack of access in certain populations, you can only imagine then the impact. When you look at healthcare statistics, I don't have the numbers in front of me right offhand, but it's a well-known fact that if you address people's mental health care, the overall number of medical doctor visits significantly reduces. There's a lot of overlap between mental health and physical illness. It's not in my bio, but I'm a health psychologist by training. So my training was to work with cardiologists, endocrinologists, people that deal with significant illness. So for instance, heart disease and depression run hand in hand. You look at people that have gone through the scary experience of having a heart attack, they have to change their lifestyle, eating habits. We have relationships with food. That's why we're overweight. And so, I love to eat. And then you take someone who's had their life shattered. Now they're giving up other aspects. There's a lot of emotional discourse. There is correlational research that suggests that there is a significant impact on cancer treatment by depression and anxiety and other mental health illnesses. So again, by us utilizing, value-based behavioral healthcare, it allows us to kind of address some of those disparities in the healthcare system and find then innovative ways to address those obstacles. I'm sure if you've watched television in the last probably 5 to 10 years, they've had a lot of those cancer centers kind of advertised in the news, and in particular, those take that holistic approach. They seem to have found a balance between mental health, medicine, naturopaths, physical therapy, everything that they can access to try and address multiple needs for people to improve outcome. Even like in 2022, so just give you some numbers here, over 100 of the largest employers in the United States started to expand their mental health care benefits. On the island, GHI, for instance, gives you 12 sessions a year. And the cost is pretty high. The copay is very high. And so if we can start to address those kinds of conversations, I believe government's the largest company on the island technically, right? And so when we look at expansion, this is what's going to drive some of that change, because obviously there's going to be an expense to the government in provision, but do the benefits outweigh that initial surge in cost? And that's why it's important for us to get into measure, because then government can see the value of its expenditure, so it's willing to invest in it. And then as the value goes up, and people are addressing mental health care and doctor visits are coming down, the overall cost is lower. And again, part of the impact then would also be we would have to warehouse a lot of all the information, the analytics using AI. So it's not only just collecting the information, it's the analysis and then the projection, and then trying to get like an outcome, an idea what the outcome might be, so we can try and meet it at the pass, right? And again, I will speak to this later. Even with the most recent breach that like Bermuda government dealt with, those that are real concerns that people have lots of questions about. So when left untreated, mental and emotional health issues do lead to higher levels of disability, loss of work productivity, job loss, employment changes, and a lot of that was organized and collected by the World Health Organization. How many times have people taken a mental health day, or how many times have I've worked with many people, obviously, on the island. In fact, I just as a rough estimate have done, probably, given the amount of time I've been there, right around 24,000 sessions. And when people are seeing people during the day and you have a rough session, you may have cried, you may be emotionally flat, maybe you've been struggling for a while, so you come in that way, and it does impact people's jobs. People then get in that chronic unhappiness, and they start to look for employment changes. They try to change things in their environment, but they're not addressing their mental health. And so they can't seem to find the right fit or the right answer, but it's because we're doing the wrong things. And, poor mental health is a massive risk factor for substance use. And you see that in chronic conditions like diabetes, asthma, cancer, cardiovascular disease, even arthritis. And, if I were to work with someone has a diagnosis of schizophrenia, it's almost always there's some kind of substance abuse problem with it. You see that many times when it's, and not all bipolar severe, but when you hit those more extreme versions, you see that overlap and risk factor for substance use. As a result, right now we don't have a standard indicator of potential issues. So the risk factors can be dispersed across many data sources and across medical and pharmacy. So using traditional retrospective tools are unable to connect dots across multiple, areas that we can gather information. It leaves people reacting to mental illness rather than preventing it or actually treating it. So that's one of the reasons why healthcare organizations are leveraging their data that they're trying to collect, so that they can develop more predictive models to connect all health and benefits data. With advanced warehousing and AI-powered predictive models, health organizations are being more proactive. They're trying to use data to guide decisions, whether that's with patients or with employees. And again, it's that preventative program tailored to meet the needs before an adverse situation happens. And then the third component is evaluating the behavioral health programs themselves. This is one of the more difficult conversations. You can do symptoms, you can measure, okay, I feel sad. And when I started the program, maybe I rated it a 10. And maybe when I leave the program, it's a 5. And so that may look like, well, okay, there's 5 points. That's pretty good, but they're also still depressed. And so what measures depression, right? What is significance and change? And I'll give you an example. Many years ago, I worked with someone who was diagnosed with schizophrenia. And it was an inpatient program. Danger to self or others was never going to be released into society. And over the course of a year of working with them, I'd go in, I'd see them pretty much every day. And every day they cursed me out, they acted the fool. And every day I came back. Over the course of time, I was allowed to take them off campus when they earned privileges. And if I gave him a Coke and a milkshake, he would have a good conversation with me. When I went to leave the program, you're thinking, wow, this person is never going to leave the program. They would attend some of the, courses, classes, things like basic, how to wash your laundry, how to cook food, the basic things that they would need. And you're kind of frustrated thinking, what kind of impact did I really have? And right at the 11th hour, as I was leaving the program and said goodbye to everybody, and I couldn't find him, he comes flying out of nowhere, grabs me by the arm and whispers in my ear, "I heard you every time you said hello." In that moment, that was change. Now, is that measurable? So again, as we're looking at performance, it's psychology again, social work, dealing with people. It's a very subjective conversation. So we can definitely measure things like symptoms. But when you start talking about that humanness of people, that's where it gets odd. And that's also why research in psychology is more based on correlational and kind of idea generating, because to get that level of precision, it's difficult. And again, with outcome based, healthcare plans, employment teams, it gives you a wide angle of metrics to understand what's driving change. How do we utilizing it? Let me give you an example. So I could tell you, when I worked in a domestic violence shelter, in the United States, from Thanksgiving till Christmas, we would see a reduction in the overall numbers. Where from Christmas to New Year's, there was nobody in the shelter. Families tended to try and pull it together, and then you throw in a bunch of alcohol in our situations, and come January 2nd, the shelter would be full. And so you see those kinds of trends. And also, I can tell you, in Bermuda, the highest service, the quarter, so January through March, I see the most people in the year. And then the second quarter would be the second. And then the summer, you see, lots of people traveling. So you see the numbers start to dwindle. And then you hit that fall time. And then Christmas, the island shuts down virtually for a week from Christmas to New Year's. There's lots of celebration, Christmas parties. So when you start tracking all these, you start to see trends. And I've done that in my practice so that we can make adjustments for it. But those are things that are important to understand. Like, for instance, when I gave the example of domestic violence, just as another example, another trend. So I'm going to speak to something here in Indiana. In Indiana, the first month of the pandemic, domestic violence rose 120%. So you can see, so if, I'm not going to put my mouth on it, but if this would ever happen again, we need to account for those things. We have to do a better job at all the secondary issues that happen when things like lockdown or trying to protect people's lives exist. So what are the potential problems with data-driven behavioral healthcare? The first is data privacy and security, right? And again, we just experienced this in Bermuda with the government being hacked. And the consequences for people is enormous. Can you imagine? I mean, your medical information, obviously that's important to most people, and people are usually private about that. But can you imagine if some of the things that you tell your therapist were to ever be extracted out into public view. It really, and with the amount of cybersecurity attacks from other governments, from individuals, it really puts a lot of people's information at risk. And so you see the panic and actually want to give that information. Also, data is fragmented. When we look at, I may collect a certain amount of data for a certain reason. There's certain things I don't need to collect necessarily the information that a cardiologist would collect. And so you see these kind of chunks. We're not all collecting the same thing, or maybe you have a different age range. Maybe you align with the government. The issue of gender. We have so many things that people kind of do and have to figure out themselves that it fragments, and it often doesn't want to. It doesn't have a lot of synergy. How accurate is the information? When we tried to do some statistical analysis in my office in Bermuda, one of the questions that people really did not want to answer was, how much money do they make? And we took some of the demographics that Bermuda government was using as kind of like the benchmark, and said, okay, if Bermuda government's collecting this way, this is how we'll collect it. And nobody wanted to answer that question. Sometimes you get there'd be an occasional flippant response, and so the accuracy and the quality of the information was not very good. Sometimes data is biased. For instance, in Bermuda, the racial breakdown is somewhere around 65 to 70% Black, right? And so if I were to simply look at medians and means and things like that, the numbers would be skewed, so it would be overrepresented. And if I didn't have enough of the white population, then it would misrepresent the overall, and then I would be making assumptions that were incorrect based on the bias of the data. And also, what that would mean then is it would perpetuate, health disparities. We'd be focusing on the wrong parts, and we'd be missing the boat. Data overload. With the amount of information. I mean, if you did this on a global level, can you imagine the amount of servers and softwares and just the sheer size of it would be huge. And that's if we could even standardize it, which is another problem. And that would be standardizing across, again, cultures, races, countries of origin. And there's so many different factors out there that between standardization and data overload, it makes it difficult to actually collect. And then again, resistance to change. I have to admit this too, as I was asked to present on this, my tendency is I put a lot of focus on the individual and empowerment. And, I see the individual side of people and what they're capable of doing. And to boil it down to a statistical analysis kind of hits a nerve with me. And so even though I like technology and I'm definitely for finding ways to utilize it, I even have a resistance to change, and I'm the one who plays with it. So, from an individual provider standpoint to just the general population, there is a resistance to change, especially when it's driven off numbers. And I say this loosely, we've kind of boiled people down to a statistic. Then you got clinical workflows. You take a system, like let's look at Bermuda Hospital, for instance, overworked. And now we're going to add all this additional workload to people trying to just get from patient to patient. And now they got to sit down and try and collect all this information so that it's measurable. So it adds a pretty significant administrative burden for people. And again, what are people going to, not do? And people are going to treat the patient. They're not going to fill in whatever that data-driven form is that they need to go through. There's, again, resource limitations. Not all healthcare organizations have the ability to implement that large of a program. In our office, we don't have servers. We're a small practice. We have 5 clinicians. And so we don't need all those large software programs. And again, it wouldn't be as cumbersome, but it would be almost cost ineffective for us, and maybe even cost prohibitive given how small of a practice we are. There's ethical considerations. Again, consent, transparency. Who's going to be seeing this? What types of information? If you're seeing, like I mentioned earlier, if you're working with a rape victim, why does a physical therapist need to know that, or why does the dentist? And so you see, how do you start paring down who sees access to what, and then you start putting walls in place, and then it becomes almost counterproductive, right? Also, you see an overemphasis on qualitative data. Much like I said, my own personal bias. Are we boiling people down to numbers? Uh, there's patient mistrust of systems. In Bermuda, many people know many people. I always joke what was that, Kevin Bacon? 6 degrees of separation. In Bermuda, it's two. And so you see people that really want to be anonymous because they may know many medical doctors, they may know many of the other professionals on the island, and they just want to stay off the radar. And then you have to throw in one of the last things is who's going to regulate all this. So whether it's a national scheme or whether it's a global scheme, you get um, you have to determine what kind of organizations would be capable of doing something that large. So to address these problems and unlock the potential data-driven, value-based behavioral healthcare, policymakers and technology providers need to collaborate on data standardization, privacy protection, and then kind of building a culture of data-driven decision making. We need ongoing training, we need support for healthcare professionals, and then help people adopt to new practices and technologies. Now, I know that's 40 minutes of me ripping through a lot of information. And what I wanted to do was kind of open up more for discussion because we're throwing around a lot of ideas. There's the obvious advantage of technology. If you think about the pandemic, many people switched to online therapy because they weren't allowed to leave their homes. People were scared, and it gave them access to the resource. And so there's an obvious benefit. And if you've noticed over the last 4 years, you saw I use GoToMeeting primarily because it's HIPAA compliant in the States, but there's other programs out there that are designed for our field, and they're used to access people. So technology has actually improved access. There are times when people would have to, maybe they're getting out of their office late, and so they would normally have to cancel their sessions so they can sneak out to their car, they can go down to the arboretum. There's things that people can do now that facilitates access, so that's a good thing. But then the flip side of it is the growth. It's the how do we protect this information? I don't know if it's still this way, but I know, for instance, Zoom in the States, unless you bought the medical version of it, you're not allowed to use that in the medical profession, and because of, again, some of the security breaches. So but if you didn't know that, you might be using that program and your quality of care is here, but then you're negotiating, okay, well, is someone's breach of technology, is that possible? So it offers a lot of conversations. Also, not all countries in the world believe the same thing. So, for instance, if I work with someone in Saudi Arabia, I would have to be mindful that their government may be listening into the session. And I have to be mindful not to criticize the government or say something that violates the value systems of that area. And so when you start getting those kinds of conversations, then you start talking about global utilization of these kinds of programs, it becomes really sticky, and it can be scary for some people. So what I'm going to do now is I'm going to shift over, let's see, to the question and answers. And if you want to ask me something, let's go for it. I prefer to make this an interaction. Anything I said that you want to follow up on, maybe some insights and ideas that you might have, anything at all. If you're unfamiliar with this program, there's a question and answer box that it says chat, polls, people, and question and answer. While I'm waiting on a question, there's one thing, I'll give you something specific to Bermuda just to kind of follow up. So when I first started this presentation, I started by defining the value-based behavioral healthcare conversation. And one of the primary features that I discussed, one of them was population health. So here's an example. It's in Bermuda. As in 2021, 13% of the population of Bermuda had diabetes. So when you look at the impact of diabetic symptoms, I mentioned depression. That's one. You have a lifestyle change. You have uh, people are scared of the needles. They're putting chemicals into their body. Lots of people have an aversion to taking medication. They want to feel better, but they have an aversion to some of the ways that we would have to address it. There are side effects often by medications, and although most times they go away or they're minimal, it still has an impact on people. And so by knowing that, so then what would we do to address those factors? What as a psychologist, when I'm working with someone who's diabetic and they may have, let's say it's a male, they have erectile dysfunction. That's pretty consistent with someone who's got diabetes. And so now not only do you have a medical concern, but now you have a relationship concern because you get that performance anxiety on top of an actual physical expression of what you're going through. And so that would be an example of knowing this information also gives us treatment protocols. It's the medications that we use. I've had cardiologists and other GPs talk about when they prescribe medication that sometimes they almost automatically have the conversation about some type of ED medication because they know it's going to come along with it. So that would be an example of by gathering information about the population, then we can use it to do more preventative. Same thing like with hurricanes. I lived on island for 13 years, and I'm guessing I saw 6 or 8 hurricanes in that period of time. And I can tell you the one that was the worst. Now I didn't. I think it was Emily and some of the other ones really hammered the island. The Faye Gonzalo, I think that was around 13, 14, somewhere in there. That one really shook people because no one expected it, and it was a tropical storm. And when I woke up that morning, I looked out the window and saw the trees bent over and the power went out, and I went without power for 2 weeks. And coming off the heels of six days after Faye Gonzalo hit, and it was coming at the island, if I remember right, at a Category 5, and then the wind shearing and the water slowed it down. The cold water being dredged up from the first hurricane, we got hit. I think it started down at 4 and then went to a strong 3. Those things rattled people. People were emotionally distraught, even though everybody was okay. The island was ravaged. I think there was over 200 telephone poles down, and you could see the remnants of that for quite a while. And I know they're on the news a couple of times. I sent in just kind of like something to say, hey, tell people it's okay to feel what you feel. It's okay to know that you're scared, that you're going to be ramped up for a while, that we got to focus on distractions, eating well, just basic things, sleep, just to kind of let people know, normalize what they're feeling, and then kind of try and help them find that path, because we all went through something traumatic. And so knowing those things, tracking people's responses and analyzing the data gives us protocol so that we can impact the community in a way that's healthy. When we talk about the delivery of personalized outreach and care, I mentioned that as one of the second impacts that data does for us. So in mental health, the research shows that a GP is always the first line of defense. Almost all times, people are going to, they know their medical doctor for the most part. They've been seeing them for a while. They talk about things. Oh, I'm having difficulties in my marriage, or I'm feeling kind of sad. I've been angry lately. They're going to address their GP before they address a psychologist, a social worker, or a counselor. And that in part is simply history, being able to talk to your medical provider, but also it's some of that stigma that still exists in most areas of the world. I laugh because, I don't know, it was probably 10 years ago, I was in Jamaica and someone asked what I did, and I said psychologist, and I got what is that? And when I described it, they said, oh, you're a head doctor. And so I laugh because, okay, that works. And when I was in Belize this summer, that's how I presented it, and everybody understood. And so when you look around the world, there's a mental health. Sometimes uh, people don't view it as such. Maybe it's something more religious based. I remember on one of my trips post pandemic, um, I took a tour with someone local. I went off the beaten path, and they said they didn't believe in the vaccine, that they had these herbs, and he pulled off the side road and he started picking all of this, and that was his way of responding to it. And so whether it's medical, whether it's psychological, when you look across the world, there's a variety of ways that people look at it, right? I mean, even movies. We've seen movies that were constructed where I think it's the what is it? Something of Emily Rose, the possession of Emily Rose, something like that. And it walks you down a fine line. Is it mental illness, something like schizophrenia, or is it something religious based? And so when we look at how to deliver these, it's knowing your communities, it's knowing your outreach, how to get that information out there, and by collecting that data, it gives us those choices, right? Um, and again, with medical doctors being the front, the first line of defense, that's again where that coordinating care, the holistic provision becomes powerful. Something else, just because I'm trying to hit lots of different things that would be impacted in the community. You know, uh, when you look at the research on homelessness, for instance, the 20 to 25% of people who are homeless, they believe have serious mental illness. And that's not depression, things like that. We're talking, schizophrenia, severe bipolar, things of that nature. And that is 4 to 5 times higher than the general population, which is usually 4 to 6%. Now, when I first started the presentation, I said 1 in 5 people need therapy, uh, and only 50% of those actually access it. That is just the wide range of mental illness, and specifically with homeless, I'm talking about the serious side of it. And if you look in Bermuda, you hear conversations. We all know who the same people are. Uh, I think it was a Jinxie that died in the past year. There's the scientist, all the people that we've talked about and we've seen. You see the necessity for mental health illness, and sometimes there are services available, and a lot of times there's not. And again, it's not we're doing the wrong thing. It's that we don't know exactly what all we need because we're not tracking it effectively. So there's a wide range of mental illness. There's a wide range of data collection. And if we had the right information, we might be able to inform our services of what they could utilize their resources for, or generate additional resources so that it could be utilized. All right. I'm not seeing any questions. I'm not that good. Anything at all that you want to ask? I see the joke about head doctor. Yeah. Well, and I had the same conversation. It was a driver in Jamaica, and I just have a bad habit of asking questions. And he told me he had sugar problems. I said, "Oh, diabetes." And he looked at me and he goes, "No, sugar problems." I go, "Okay." So I giggled. Is there any area that I presented that you'd want me to follow up on? Anything at all in the last few minutes? There is also like a poll and option for here. And while I'm thinking about it, um, maybe not necessarily use the poll, but and I don't know, there's no way to raise hand. I guess probably one of my questions would be for everyone in the room would be, how comfortable would you be collecting data, the things that you do in your practices, the things that you do in your organizations, and putting that into like a national or global database. I know I struggle with that concept. I see the value of it, but my desire to protect you being anonymous and your autonomy is in conflict with that. So I don't know if anyone has any insights on that or anything they'd like to share. Okay. Well, I know this topic is a little bit dry. When we look at our future, we see the AI coming. It makes everybody nervous. We've seen a lot of Terminator movies. We see the impact of data. We see breaches. We see inconsistencies. So this topic can produce a lot of good information that can really drive us into the future. It just comes with a lot of unknowns right now. And I think that we're probably still scraping the surface of how to do that, how to collect effectively, how to protect them. I think probably the protection of information is the most significant for most people. And then I think finding ways to collaborate, to utilize that information, it would be essential. So, you know, I, I am a guy who likes to use research. I tend to try and do a lot of things through empirically validated and trusted sources. But I also know that there's a lot of subjectivity in what we do, and I never want to remove the human factor from where, at least when I practice. I appreciate the opportunity to give you this information, and I hope that some of it can be useful in your practice going forward. Oh, I see a question here. I'll go back through it. Sorry. Tell mental health. How is it? And how is it being utilized? Uh, so I go back and forth between the United States and Bermuda, and I started doing telehealth in 2014 for a lot of people that were traveling, and over the course of time had utilized different software programs, um, as well as different types of hardware. And I think around 2018, I spent 5 months really digging into it, and then and started utilizing in 2019. And so I think a lot of providers on the island have, well, obviously the pandemic forced it. Um, but I know that in our as a practice, it's given us a lot of utility for the providers that when some of their people travel, when some of their people have life events come up, maybe they needed to take their child to daycare and the provider was ill. And so you've seen it's really given us a greater access to meet the needs of people and using it in a variety of ways. People can download it on their phone. The programs now don't chew up data as badly as they used to. So people are able to, it's created greater access to people when life events happen. Um, Sometimes, what it's also done, people don't like sitting in the waiting room. They are uncomfortable knowing that other people they may bump into are sitting across from them. And occasionally it does happen, right? You go into the doctor's office, and if you're going into a GP, you really don't know why people are there other than maybe they're sick. When you come into my office, you kind of know what's going on. You may not know personally what's going on, but you know why people are there. And people are still, there's that stigma behind it. And it's just that issue of privacy. So I believe telehealth has also opened a lot of doors for people that would otherwise have struggled to come into the office. one of the I'm just going to jump on that question a little bit more. Sometimes people ask about, do you lose something by not sitting in the room from people? And the answer is a little bit yes and no. One of my strengths, I pick up on very subtle changes in skin tone, um, a facial reaction, and the high definition cameras have actually enhanced that. If you notice, I have red cheeks. First few times I started telehealth, uh, one of my clients asked me why I was wearing makeup, and I laughed because my cheeks are always rosy red, and they just never noticed it before. But the clarity of the picture uh, made it easier for them to see it. And so, um, for me, telehealth has not seen too much of a drop in some of those other variables that we look for when we're doing therapy. I think where it becomes a problem is sometimes it's better to be sitting across from someone. Sometimes people need that physical presence. And I'm lucky enough to still have my office in Bermuda, so people still go in my office even though it's still telehealth. So there's still the privacy of the office. We in an office, you can protect someone's privacy much better because you can control the environmental variables. Um, but in general, I haven't seen too much decline, and I know other providers in the office have utilized it and it's created better access for people. Well, once again, it was an honor and pleasure to present for you, and I appreciate your time. I'm going to hang around for a few more minutes if you have any questions for me. All right, I am going to be exiting out.